This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Arctic. Want to know what toxin in the local diet affected Arctic explorers in the 1800s, but not the native people? Which body part reflects brain swelling? And what did the ancient Egyptians use to treat night blindness? Listen to find out. Today's episode starts in Alaska, where you're moonlighting in an emergency department, planning to combine it with a few days of vacation afterwards. You've read up on frostbite and hypothermia in preparation. Your first patient, however, has neither of these problems, but is complaining of a headache. He's a 50-year-old man with the worst headache of his life and blurry vision. He can barely see, and in addition is having visual spots and flashes. He also reports generalized malaise and fatigue, along with nausea and abdominal pain. He denies fever, neck pain, and all other symptoms. His only past medical history is significant for a gastric bypass 10 years ago, i.e. weight loss surgery. He doesn't take any medicines or supplements and denies tobacco, alcohol, or drugs. He works as a truck driver. As usual, we start with a physical exam. His temperature is 98.5 Fahrenheit or 36.9 Celsius. His heart rate is 80 beats per minute, blood pressure 130/80, respiratory rate 18, and oxygen saturation 100%. So completely normal. His physical exam is also completely unremarkable except for his visual acuity. He can barely read the largest letters on the bottom line of the eye chart. So far, this appears to be a very straightforward case with a clear diagnostic approach. When you go to the emergency department with a headache and say it's the worst headache of your life, we immediately start down a path to rule out meningitis and encephalitis and subarachnoid hemorrhage due to causes like a ruptured aneurysm. So first, we order a CT scan of the head and some basic lab work. And if those are negative, then in many cases, we perform a lumbar puncture, i.e. a spinal tap. CT scans can occasionally miss small amounts of blood in the brain, and to avoid missing this life-threatening diagnosis, we send the spinal fluid to the lab to check for blood, and also we can check for infection. So you also order pain medicine for him to treat the headache. On further reflection, while waiting for the results, you note a few unusual features. Migraines commonly cause severe headaches and visual changes, but our patient has no prior history of migraines. Of course, anybody can get one anytime, but onset at his age is unusual. In addition, he's complaining of right upper quadrant pain, though he didn't have any tenderness there on exam. It's not uncommon for patients to have both headaches and abdominal pain with things like stomach viruses or the flu, but it is unusual with a patient complaining of the worst headache of their life to also have abdominal pain at the same time. So his head CT is normal, there's no bleeding, brain mass, or any other abnormality. His lab work shows elevation in his liver function tests, but is otherwise unremarkable. It's not clear exactly what to make of that, but it's definitely not an emergent issue. The headache definitely is an emergent issue. So you go back to check on him and convey the results. He says the pain medicine hasn't helped the headache. Definitely the next step here is the spinal tap. After getting the needle into the thecal sac containing the spinal fluid, the first step is to measure the pressure, a reflection of the pressure in the fluid around the brain. So you attach a manometer to the needle, and this is a long, thin glass tube. As soon as you attach it, CSF shoots out the top of the manometer. Uh-oh. This means the CSF pressure is more than 30 millimeters of mercury. Normal pressure is around 10, meaning he has intracranial hypertension. You send a few cc's of the CSF to the lab for analysis. As you remove the needle and clean up, you reflect on diseases causing intracranial hypertension. The list includes things like meningitis, encephalitis, intracranial hemorrhage, tumors, lupus, venous sinus thrombosis, and endocrine diseases like polycystic ovary disease. You order an MRI for further evaluation. However, this isn't a neurology podcast, it's a toxicology podcast. But first, question number 1. Which body part shows intracranial hypertension when present? A, the eyes, B, the lower back, C, the nose, or D, the neck? The answer is A, the eyes. Papilledema is swelling of your optic nerve reflecting increased intracranial pressure. If you look into the back of the patient's eyes, you can see the swelling. It's difficult to do, and while technically possible in the ED, it often requires a dilated eye exam and an ophthalmologist to be able to see it. Let's focus on toxins causing increased intracranial pressure. Interestingly, some antibiotics, classically tetracycline, but also penicillin and doxycycline can cause it. Steroids like prednisone and oral contraceptives, lithium, lead, ketamine. You get the results of his lumbar puncture, negative, no sign of meningitis or encephalitis, and no evidence of bleeding. His MRI is also negative. This is all good news, but it leaves us with no idea what's causing this intracranial hypertension. Having ruled out the truly emergent problems, you take another look through his chart. There is one clue: the elevated liver function tests. Steroids can cause both liver disease and intracranial hypertension. However, the pattern of the liver test is wrong and the patient denies taking any medicines or supplements. Question number 2. It's time to pick your poison. This is classic for which vitamin toxicity? A, vitamin A, B, vitamin B12, C, vitamin C, or D, vitamin D? The answer is A. These are the classic symptoms of hypervitaminosis A, or vitamin A toxicity. It's a rare diagnosis, so confirmation would be important. We wouldn't want to confuse it for another rare disease. You can send a vitamin A level. It'll take a week or so to come back, and it can be difficult to interpret. The gold standard is actually a liver biopsy. And if you do a biopsy, it shows characteristic findings of hyperplasia or swelling of stellate cells. These were formerly called Edo cells, with fluorescent vacuoles stuffed with vitamin A. The biopsy will probably take a few days. In the meantime, our patient still has a headache and still has blurry vision. We need help from neurology, and we need to get him admitted to the hospital for ongoing treatment. If the intracranial hypertension gets worse, he'll progress to vision loss, seizures, and coma. Neurology recommends treatment with acetazolamide. It's a diuretic, i.e. a water pill. It doesn't affect vitamin A, but it can reduce increased intracranial pressure. It's the same drug we use to treat cerebral edema due to altitude sickness. Steroids might help, and I know I said earlier they themselves can cause intracranial hypertension, but not in the short term. If medicines don't help and he gets worse, you can actually drain out the CSF with a therapeutic spinal tap. So you order the medicines per neurology recommendations and get him admitted. Likely he'll be admitted to the ICU for frequent neurochecks to make sure he doesn't deteriorate. Putting all of this in motion gives you a chance to ask the biggest question: where did the massive amount of vitamin A come from? How was our patient exposed? He mentioned a gastric bypass. Could that be the culprit? No, patients with bariatric surgery at risk for malabsorptive diseases, meaning not extracting enough nutrients from food. They're actually at risk for low vitamin A levels, not high. A common source of hypervitaminosis A is supplements. Patients can take way too much, so you ask him again about supplements, and he emphatically says no. You tell him you suspect vitamin A toxicity, and a very surprised look crosses his face. After some further discussion, the source of his exposure becomes clear. Question number 3. Eating which of the following results in high vitamin A exposure? A, quails, B, polar bears, C, pufferfish, D, mushrooms. The answer is B, polar bears, specifically polar bear livers. Our patient ate part of a polar bear liver a few days ago. He's a truck driver, as mentioned in the history, and says he's been having difficulty with night vision. He nearly struck a pedestrian after dark 1 month ago. Distraught, he did some research online, finding that night blindness can be due to low vitamin A levels, which he also found could result from his gastric bypass. Rather than visit his primary care doctor to have vitamin A levels checked and supplementation recommended, etc., he decided to fix it himself. Why? He recently lost his medical insurance due to a job change. Our patient's background is Inuit, native Alaskan. His mother sent him some polar bear meat, and at his request, the liver. She advised him not to eat it. They both know polar bear livers are toxic due to high levels of vitamin A. Ignoring her warning, our patient ate a few bites, hoping to improve his vision and expecting to avoid toxicity. What he didn't realize was just how toxic polar bear livers really are. Let's talk a little bit about vitamin A toxicity and then come back to our patient. Question 4. What's another name for vitamin A? A, thiamine, B, niacin, C, ascorbic acid, or D, retinol? The answer is D, retinol. Vitamin A refers to a group of retinoids, including retinol, which is vitamin A1. So knowing this gives us insight into how vitamin A works. Retinoids have multiple functions in the body, responsible for growth and development of embryos, immune system function, and they're critical for vision, especially night vision. They maintain growth and development of epithelial cells, especially related to mucus and keratin. Thus, the reason we have retinols in skin cream for aging, acne, and inflammation. Vitamin A deficiency is rare in the US and Western Europe due to plentiful dietary exposure. It's found in liver, fish, eggs, and dairy products. It does occasionally occur after a gastric bypass with inflammatory bowel disease like Crohn's disease, and it is common in patients with cystic fibrosis. Deficiency is much more common in Africa and Asia. A fascinating fact I didn't know before I did this episode is that deficiency increases the risk of death from infection, especially measles and infectious diarrhea. Vitamin A deficiency also causes night blindness and problems including complete vision loss. It causes skin changes due to disappearance of mucus cells and replacement of normal epithelium with a keratinized or dead, tough epithelium, resulting in dry, peeling skin, broken fingernails, and hair loss. In fact, it's keratinization of the cornea that causes blindness. Perhaps our patient's night blindness was due to vitamin A deficiency, but now he definitely has the opposite problem. Vitamin A toxicity can be acute, as in the case of our patient, or chronic. 10,000 international units of vitamin A is a generally safe amount, and toxicity starts at around 25 to 35 international units. Our patient has the typical symptoms, including blurry vision, increased intracranial pressure, and evidence of liver damage. Vitamin A is stored inside the liver cells, so if you eat it or take too much, then the liver cells swell up due to excessive storage, and this results in cell death and liver cirrhosis. The pathophysiology of intracranial hypertension is not well understood, but vitamin A may disrupt membranes, resulting in disruption of CSF outflow, and it may modify gene expression involved in CSF secretion and absorption. Chronic exposure, as I've mentioned, results in different symptoms, occurring with consumption of more than 4,000 international units per day for longer than 6 months, most often with excessive supplement use, as I mentioned. Chronic exposure also causes cracked and peeling skin. Interestingly enough, hair might become permanently curly or kinky. Mucous membranes like the mouth and nose are very dry, and patients also have severe bone pain from changes including demineralization of the bones. Polar bear liver toxicity has been recognized by Inuits at least since the 1500s, aware that ingestion caused headaches and prostration. European explorers discovered this the hard way for themselves later in the 1800s, but it wasn't until 1942 that vitamin A itself was isolated as the cause. And it's not just polar bear livers that are high in vitamin A. There's a lot in beef liver, as well as very high levels in seal livers and seal fat, also shark, tuna, and sea bass livers. So back to our patient. What happened? I mentioned potentially toxic exposures start around 25 to 35 international units of vitamin A. Polar bear livers contain extremely concentrated amounts. One of polar bears' favorite foods is seal, and seals have extremely high amounts of vitamin A in their livers and their blubber. So to keep the bears from becoming vitamin A toxic after eating, their livers have evolved to safely store high levels. Just how much? Astonishingly, 25 to 35,000 international units per gram. For Americans who might be unfamiliar with a gram, it varies with weight, but for example, 1 gram of salt is 1/6 of a teaspoon, and 1 gram of water is 1/5 of a teaspoon, meaning very, very tiny amounts of polar bear liver contains a potentially toxic amount. Our patient reports he took only a few bites, but still way more than enough to cause toxicity. A polar bear liver weighs somewhere in the neighborhood of 20 pounds and is estimated to contain enough vitamin A to kill 52 adults. For comparison, 1 gram of beef liver contains only 180 international units of vitamin A. You can develop toxicity from beef and fish livers, but you have to eat a lot, not a tiny part of a tiny bite. Side note, eating polar bear meat is restricted in many parts of the world due to their endangered status. Native Alaskans are allowed to consume the meat, which is perfectly safe health-wise. The risk is only due to the liver. Our patient continues to worsen with increasingly severe headaches and visual changes. He develops lethargy and becomes comatose. There's no antidote for vitamin A toxicity. Treatment is removing the exposure. Neurology does another lumbar puncture and drains off CSF to reduce the intracranial pressure. The ICU continues supportive care, and his liver biopsy confirms vitamin A toxicity. Fortunately, he not only wakes up but also recovers his vision. This is a fictional case, as are all our cases to protect the innocent, but it is based on real poisonings. Question number 5. Liver, as a remedy for night blindness, was recognized as far back as 1500 BCE by the ancient Egyptians and is noted in ancient Assyrian, Greek, and Chinese texts. Which methods of application were used to treat night blindness? A. Rubbing liver oil on the inside of the eyelids. B. Ingestion of liver. C. Leaning over a cooking, steaming liver so the moisture goes into the eyes. Or D. All of the above. The answer is D, all of the above. I came across a really interesting article written by a physician who grew up in the United Arab Emirates. At night, they had no electricity, so it was pitch dark, and his father developed severe night blindness. An elderly medical practitioner recommended grilling a fish liver, then applying the oil from the liver to the inside of his father's eyelids. Amazingly, this worked. Ancient Egyptians knew eating liver cured night blindness, and other texts recommended putting your eyes over a steaming liver so the moisture went right into the eyes. Last question in today's podcast. We've discussed why polar bear livers have high vitamin A, but why do seal livers and seal fat contain such high quantities? A, to help their immune systems, B, to help them grow quickly, C, to help them swim faster. Follow the Twitter and Instagram feeds, both at PickPoison1, and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Thanks so much for your attention. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available on the website at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.